Good morning. Welcome to AngelTrack software. This is Alex. Today, what I'd like to cover in this video is demystifying EMS billing and things an owner should know about the billing process. These are things when I ran my company I wish I'd known, and it took me years to fully grasp and get a whole handle on, digging for these rules, explanations, and understanding of the process. Today I'm going to be able to cover that in under an hour with you. So, things an owner should know about the billing process. First, I'd like to go into our disclaimer that this is not legal advice. Here at AngelTrack, we do try to keep you informed of any major CMS regulation changes. However, your biller, inside or outside, should be able to keep up with all of your local, state, and national regulations that apply to your particular service. So a lot of owners come to us and they're trying to decide whether they're going to use an outside billing agency or bring their billing in-house. Here are the advantages and disadvantages to both. An outside billing agency, you have less immediate oversight. This can bring about some communication issues where there's some delays when you need to know some information, but you have to contact them, wait a little while before they get back. Maybe you're playing phone tag, things of that issue. The cost of an outside biller is normally based on a percentage of the revenue that they actually bring in for you. This is a good thing. Be aware, though, there are some outside billing agencies that use their own in-house collection service. And that collection service may be charging you a higher percentage of revenue that they receive. If this is a fact, a lot of times the billing agency now no longer has that incentive to push things clean through the first time. They don't mind if it goes to collections because they're going to collect more money on that end. Using an in-house biller, you do have a lot more control and oversight on the process. There are some cost issues that need to be understood. An in-house biller, you're going to have your regular payroll costs, insurance costs, regular employment costs of adding another employee. One of the biggest issues with an in-house biller is the staffing issue. Locating, recruiting, and retaining a qualified in-house biller. By qualified, I mean someone who is educated in EMS billing, ambulance billing, preferably with a CAC qualification, which is a certified ambulance coder, not just a medical billing background. There are also some routine education costs for using an in-house biller. They are going to need 1 or 2 days every quarter just to do their CE, attend webinars, remain educated on important compliance and revenue issues that you may be facing. This is one important thing I can't stress enough. Whether you're using an outside or inside biller, remember that a physician or clinic biller is not an EMS biller. EMS is a specialty. We have our own rules and our own best practices and our own compliance issues. So I'm going to cover some basic questions when discussing and looking at choosing a billing agent, whether out of house or in-house. One of the questions you should be asking any billing agency is, what is their days to bill? How many days until your claim is actually in the hands of the insurance company? I'm going to be flat out, if your days to bill is over 5, you should find someone else. Anything over 5 should be unacceptable. A days to bill routinely is going to be 3 days with software that talks with your billing agency. You can narrow that down to 1 day, maybe 2 days after it's checked and then sent, and received at the insurance carrier. We do this electronically. Everyone has to move to electronic. What is their days to response? Days to response means how long do you have to wait when that claim is sent out before you know whether the carrier has accepted that claim. I'm not talking about adjudicating, which is giving you a payment or denying it based on the merits of the claim. I'm talking about accepting it. The basic information that's there. Did it get denied because of an incorrect birth date, incorrect social, bad coding, things like that? Can you do a live claim status checking, or do you have to call someone, have them look it up, then get back to you? You should be able to do live claim status checking either through Medicare, Medicaid's direct portals, the carrier's direct portals, or have a login to your clearinghouse yourself. You should be aware that Medicare pays you 14 days after a claim has been received electronically. If a commercial insurance, they normally take about 30 days, give or take, but if you are averaging more than a 45-day before payment from a commercial insurance, you need to look into the follow-up process that your biller is using. I'm going to talk about two collection rates that are normally given to you by a biller or a billing agency when they're trying to get your business. And a lot of people use these rates to evaluate their billing agency, but these numbers are easily manipulated. They're highly based off your payer mix. You should not be using those. A better number to ask for when you're dealing with an agency or a biller is the average cash collection per patient per trip. How much money actually comes in per trip? And this dollar amount should be higher than the Medicare allowable for your area. So first I'm going to show you these two different collection rates that companies promote, and we're going to go over them. The first one is, what is your gross collections? So your gross collections percentage is figured from your gross receipts divided by your gross charges. Gross receipts divided by gross charges. Your net percentage, that is your gross receipts divided by your gross charges after you include allowances. So your net collections percentage is a better metric than your gross collections percentage. But they're both useless. Okay, here's an example of why. Company A, we've got our average charge, so what they bill out is $300 per trip. They collect $300 per trip. So that's including after adjustments and everything else. Their gross collections percentage is 100%. Their net is 100%. You know, that's wonderful, 100%. They're bringing in a revenue of $3,000 on 10 trips. That's average. Okay? Now let's look at Company B. Company B has an average charge per trip of $1,500, and they collect on average per trip $350. So their actual percentage rate is 23%. 23%, a quarter of Company A. So if you were just given these percentages, you would obviously go with Company A. They have a higher percentage. But when you look at the actual revenue, the money that comes in, the cash collected is $3,500. So although their percentage is so much lower, they collect more revenue. And this is why cash per trip, how much do they actually collect, is the best metric you should be using. Now, notice we have this big difference in the average charges. In a lot of services, they say, well, Medicare only charges this. Medicare limits what it pays. It does not limit what you can charge. Other payers, private carriers, may pay up to 100% of what you bill. Okay, this is where the subsidizing comes in. These private carriers are going to subsidize your Medicare transports. This is also why your payer mix is very important, and you should always be aware of it. Okay, unless you are regulated by local jurisdictions such as a city, county, state, and normally even those regulations, I know for a fact in California, Los Angeles, they do regulate. They have a city regulation on how much you're allowed to bill, but it's still roughly $1,200-$1,400 per trip. That way you can subsidize. So unless you're regulated by a local jurisdiction, you're free to set your rate as you see fit, as long as Medicare and Medicaid are not charged more than other people. Another revenue consideration is, do you charge for response? So for your dry runs, for going out and not doing anything, no patient, things like that. Do you charge for treat no transport? Is your biller even aware that the code Alpha 0998, which is a billing code for treat no transport, are they aware that some payers will pay for that? So those are questions for your billing agent. A couple of other questions for your billers. What kind of training do they have? Do they receive? Are they CAC, Certified Ambulance Coded Qualified? Are they specialty trained for EMS? Can they tell you the difference in CMS billable service levels in easy to understand language? Can they provide you actual 835 and 277 files? These are the electronic files, so that you can verify and reconcile. Do they provide you a way to do reconciling? Are they transparent? Is there an easy way for you to track the rate of denials and the reasons for those denials? Improper coding leads to denials, but more often, most denials are the result of a sloppy process. Incorrect spelling of the patient's name, wrong date of birth, wrong Medicare Medicaid number. These are sloppy process denials that are easily corrected before you even send the claim out. And if you're getting denials based on these reasons, your biller should immediately be contacting you, and you should be looking at ways to fix those before the claim is sent, before you have to wait that 14 days, that 30 days for a denial, tying up your cash flow to refile your claim. If you are following compliance regulations, your billing company should not get a lot of denials. If they are, you need to look into it because they aren't being careful and they're making preventable mistakes, coding errors, information errors, things that are easily fixed before the claim is sent in. So I'm going to go into some of the rules that you need to know as an owner in this process. You need to know about PCS forms, medical necessity, IFT and SNF rules, prior authorizations, and signatures. We're looking at 5 sets of rules. You need to understand how claims are sent, so you know the process. When they tell you something's tied up here, tied up there, you should know that process. You also should understand the difference in emergency versus non-emergency and the difference in your service levels. PCS forms. Physician certification statements, you should be used to them by now. They've been in place for many years. They are for just non-emergency transports, not emergency. A PCS is basically a written order by a physician within 60 days of the transport. 2 simple rules for a PCS. If it is a facility resident, such as a nursing home, hospital, and they're under the care of a physician, you have to obtain a PCS within 48 hours of the transport. You can obtain it well in advance, 60 days in advance. However, if you're unable to obtain it before the transport, you have 48 hours after the transport to get this PCS. If they are not under the direct care of a physician at a facility, you have 21 days. This would be a home patient who is going out to see the doctor, things of that nature. If you're unable to obtain a PCS, whether from a physician within 48 hours or from the physician after 21 days, you must have documentation that you have attempted to collect this PCS. You need to write that down. That's called due diligence. That also applies when we get into prior authorizations. You need documentation that you attempted to collect it. Now, there is no specific format for PCS. However, there are signature rules regarding PCS forms that you should be aware of, your biller should be aware of. The PCS form must be signed by someone with medical knowledge of the patient, so a medical professional with knowledge of the patient and their condition at the time of transport. It may be signed by a transport coordinator or an RN for 1 day. However, in order to have a PCS valid for a length of time on repetitive scheduled transports, it must be signed by a physician. Make sure that you understand medical necessity from the side of CMS, Medicare, and Medicaid agencies. Medical necessity means that the patient's condition requires both the service level and the ambulance transport. I commonly teach owners and supervisors and managers to break down a transport's medical necessity into 2 actual things: reason for transport, why they're going where they're going, and reason for stretcher. Why do they need to be in the back of your ambulance with a medic? If you look at these as 2 separate things, it's much easier for medics to define these. A warning when it comes to using bed confined as a reason for stretcher. Bed confined means that the patient must require and meet all 3 of these rules. Unable to get up from bed without assistance, unable to ambulate, unable to sit in a chair or wheelchair. I teach medics, if you walk in to a patient's room to collect them and they have a wheelchair in their room, you need to find out more specifics on why that patient needs a stretcher. Because if they have a wheelchair in their room, they may have most recently become bed confined. From experience, I can tell you, if they have a wheelchair in their room, more than likely they do not meet bed confined criteria. So you need to make sure you get a valid reason for stretcher. In some cases, medical necessity is assumed and doesn't need to be proven. However, it does need to be documented. That's important. Your medics do need to be documenting these reasons for a stretcher. A couple of these that people commonly make a mistake on. Medics may say the patient required oxygen. That may meet medical necessity if and only if the patient's unable to self-regulate their oxygen and you have documented why. Or the patient has a fracture or suspected fracture. Anytime you have to do immobilization during transport of a fracture that has not been set or a possible fracture, perhaps you're doing spinal immobilization, hip immobilization, document it. But those are valid medical necessity reasons. The bottom one here is could only be moved by stretcher. Again, it's about documentation. We need to get that reason for transport and reason for stretcher well documented. Special rules regarding inter-facility transport. Now, I'm not going to dig too much into this. You just need to know this rule exists. It's called the campus rule. Campus rule basically states the inpatient-outpatient relationship when you are sending a provider between two locations that are within 250 yards of each other or on the same medical campus, pretty much a parking area, or share the same MPI. So there are quite a few rules there. Normally they rotate around outpatient to inpatient transports, inpatient to outpatient transports, and outpatient to outpatient are normally billable as long as your campus rule is met. Meaning you're leaving that 250-yard range, you're in a completely separate, unconnected building. They're not even connected by parking lots. Maybe it's miles away. Yes, they share the same MPI, but they are not on the same campus. Another important thing with billing is inpatient to inpatient. With some exceptions, is normally a Medicare Part A. This is why a SNF discharging a patient directly into another SNF. So we're looking at an inpatient going to an inpatient. That's a Medicare Part A. You have to bill the SNF. It's covered under their reimbursement. At the end of the video, I'm going to give you a link to a billing guide that I highly recommend from a third party that really covers this campus rule in case you'd like to understand it a little more. Some special rules regarding skilled nursing. What is covered by Medicare Part B? Generally, when I say Medicare in the ambulance industry, I'm talking about Part B. That's what our service is normally paid by. What is covered? Transport for initial admission. So we're looking at an outpatient status moving to an inpatient status. Transport home upon final discharge. We're looking at an inpatient moving to outpatient. A SNF to dialysis. This is because ESRD is covered under a special rule we're going to go into in just a minute. SNF to SNF. So this is an inpatient to inpatient. However, it's only covered if that patient is not under a Part A covered stay. And then a final note on hospice patients. Hospice patients, you must bill the hospice agency unless the transport is completely unrelated to the patient's terminal condition. So if their terminal condition is lung cancer, but you've been called out there because they've broken their arm or they've fallen, maybe a possible hip fracture, something to that effect, that's unrelated to their terminal condition. This is about documentation. A lot of times hospice, if you're billing Medicare, you're going to need further documentation. So what are some of those exceptions about outpatient services? Dialysis is one, so ESRD services. Cardiac caths, CT scans, MRIs, angiography, lymphatic and venous, and radiology therapy. Let me cover radiology therapy a little bit better for you. This is in the aspect of private insurance carriers. Be aware, private insurance carriers frequently will not pay for the first 30 to 45 days of chemotherapy or radiology therapy transports if the patient is in a nursing facility. So make sure that you get proper authorization from their carrier. Ambulatory surgery involving the use of an operating room. This includes insertion, removal, or replacement of a PEG tube in a GI suite. This is a common one people ask me about. If the PEG tube requires surgical insertion, then that outpatient service may be covered. Those are the basic SNF rules, transport rules, medical necessity guidelines. Remember, all transport should be medical necessary at the time of transport. Prior authorizations. Prior authorizations, non-emergency, often at least 24 hours in advance. Some carriers, but not all, may require a little longer than 24 hours. It's very carrier dependent. Normally, a prior authorization must be completed by the sending or receiving facility. Very few private insurers will accept the actual provider submitting for a prior authorization. Almost no Medicare Max or Medicaid offices will accept a prior authorization request from the actual transporting provider. Make sure that you document requests to a facility that prior authorizations need to be done, either by fax, recorded phone line, or email. This is important. When you take the call and you know that it requires a prior authorization, make sure that you tell them that it needs a prior authorization. There are some states where the Medicare prior authorization program is already in place. As of the recording of this video, that is currently scheduled. That Medicare prior authorization program is currently scheduled to go nationwide January 2017. So make sure you talk to your biller or a consultant about how this may affect you. The reason the documentation of due diligence of you asking the facility for that prior authorization and informing them they need it is important is many Medicaid and commercial insurers fall under a special Federal Register rule that if you have due diligence, they will pay for that transport if it is covered, if it's a covered service. Now, they're not going to pay up front, when you first send in the claim, you're going to get an initial denial, and then you're going to have to appeal, showing your due diligence documentation. Signature rules. There are 2 signatures you should always be obtaining on a transport. One is the signature authorizing the transport, care, and billing of a patient. And your second one is a receiving signature showing that you actually dropped the patient off. It's very simple. 2 signatures on a transport. Frequently, a receiving signature facility such as a dialysis center may refuse to sign. If they do, they are required to provide a copy of a patient log showing that the patient was received at that facility and when. You need these 2 signatures. Who can sign? The patient, if they're AAO 4 and capable, a guardian, relative who receives benefits, representative of the facility. And here I say that did not furnish, so not one of your employees, a representative of the facility where you picked up or dropped off. As a last resort, your crew members can sign if no one was available or capable of signing. However, they need to document the reasons why no one was capable of signing. Okay, that's a last resort. You should be getting us 2 signatures from one of either the sending or the receiving facility. CMS regulations do allow the use of a lifetime signature, commonly worded as "I allow transport now and in the future," things of that nature. However, these claims are often denied due to the presence of a lifetime signature and end up going to appeals. Therefore, it is best practice just to get these 2 signatures on every transport. The actual billing process is pretty simple. There's the responsibilities of the EMS provider and then those of the billing agency. The provider should be handling your PCS, prior authorizations, and doing a eligibility check before transports for scheduled non-emergency calls. The EMS provider obviously handles the transport and produces a run report. And then they should be doing their QA/QI as far as medical protocols, and also doing data QI to make sure their crews are collecting all the information that a biller needs. The billing agency should be verifying eligibility again before sending a claim in to make sure they're sending the claim to the appropriate person and that they have the appropriate information. They're going to be coding the claim, sending and receiving it. Normally this is done electronically. However, there are times when you may have to use a paper form. And they should be providing reports back to the provider. We're going to get into the actual process of filing a claim. The first thing to understand is, are you electronic or paper? Be aware the ASCA, Administrative Simplification Act, made the rule that initial claims to Medicare carriers must be in electronic format. So you are using electronic. Even if you submit something in paper initially, at some point that is converted before it gets to the Medicare carrier. Appeals may be on paper. They can be done electronically, oftentimes through a portal directly with the carrier. If you have under 25 full-time equivalent employees, you may use paper claims. There is no reason for using paper claims. Everyone has moved over to electronic. With electronic claims, you get faster payments, better cash flow. You get lower days to bill. You're going to get these electronic claims out and decrease that time before your payment events. You get a faster response from your carriers. You don't have to wait when you send. If you send a paper claim in, you may not get a response whether that claim was accepted for a week, 2 weeks. If you send in an electronic claim, you should get that within 24 to 48 hours. You'll know if it was accepted. This allows you to improve your processing efficiency, getting those preventable mistakes fixed quickly at the beginning of the process. Electronic claims also allow you to enhance your service that you provide. You're able to locate these claims, answer questions for people that call, and they require less hands-on oversight. Most electronic software will have scrubbing of some kind where it makes sure information is valid, things of that nature, allowing you to give it less oversight and free up your hands to focus on other areas of your business. So here's the electronic process in a nutshell. You create, either through your billing agency or billing software, you create this electronic file called an 837P. That's just the name of the file. This electronic file is created and given to a clearinghouse. The clearinghouse then gives you an electronic file back called a 999. All this is a file saying, this looks good, we're going to send it forward. Or it says, this did not make it past our information scrubbing. You need to fix this or that. At that point, they take that same 837 that you sent them after it's been scrubbed, and they give it to the appropriate insurance carrier. So they're an intermediary. This way you don't have to manage all of the insurance carriers. There are thousands of them. The clearinghouse handles that. You just send your one file to the clearinghouse. They send it on to the carriers. The carriers then send back a 277. This is similar to the 999 file from the clearinghouse. All this file says is, we've received it, it looks good, we've located this policy. That's all it says. And then, after a given time frame, the carrier makes its adjudication decision, whether it's a denial or an approval, how much they're paying, and they send back an 835 file. And that is your EOB. The 835 is your EOB. So an 837 is your claim, goes to the clearinghouse. Clearinghouse sends back to the insurance companies. They let you know, so they send it to the insurance companies. Insurance companies let you know everything looks like they've located everything, so they're processing the claim. And then they process it and give you the EOB back. And this is all done electronically. It's a very simple, straightforward process. You create the file, you give it to the clearinghouse, they give it to whichever insurance carrier, they get back a response, they give the response to you. The next section, I'm going to cover service level definitions. This is emergency, non-emergency, BLS, ALS, ALS2, SCT, or MICU in some places is what it's called. Service levels. The first thing to understand about service levels, is a call emergency or not? Remember, we have those prior authorization rules, those PCS rules. Those are all for non-emergency transports. Here we're looking at the actual definition that CMS uses for emergency or non-emergency. A rule to take note of: lights or sirens are not relevant to the billing determination of emergency versus non-emergency. They're relevant locally and statewide when you're reporting information, when you're dealing with local regulations. However, on the billing determination side, lights or sirens are not relevant. An emergency response is one where you utilize dispatch 911 equivalent dispatch protocol and an immediate response is in place. So you begin as quickly as possible to respond to that call. Again, the two things before the call that will qualify it as an emergency is you meet the standards of a 911 dispatch protocol and you begin as quickly as possible to take the steps necessary to respond to the call. If you did not use 911 equivalent dispatch protocol, then whether it's emergency or not is going to be determined by the medic at the scene based on the patient's condition. This is why we recommend that any dispatchers you utilize go through an emergency medical dispatch course and have a certificate. This shows that they understand protocol and that you have access to 911 dispatch cards or tools depending that comply with your area's regulations. So that's emergency versus non-emergency. Different service levels. BLS is fairly simple. You must meet state and local laws for staffing. Transport must be medically necessary. Very simple. ALS. ALS means that an assessment has been done by an ALS provider. This is an intermediate paramedic. So by an ALS provider or at least one ALS intervention. There's a caveat here. If you're doing an ALS certification as a service level based only on an assessment, the chief complaint must be an ALS level complaint. There's a lot of gray area there. So we recommend if you're billing ALS, you're going to have not just an assessment, but also at least one ALS intervention. People commonly ask me, what's an ALS level chief complaint? Part of that's going to be determined by your local regulations. For many areas, cardiac arrest would be an ALS chief complaint, respiratory arrest, things of that nature. ALS2, this is a step up of ALS. ALS2 means that you've administered at least 3 different dosages of medications by IV. This means actual different medication administrations. Not, I've given them the first bit of normal saline or the first bit of fentanyl and then a minute later I give them the rest. That's not 2 administrations. That would only be 1. So at least 3 different medications by IV, medication administrations. Or one of the following: manual cardioversion, ET intubation, central lines, pacing, decompression, surgical airway, or IO lines. One of the things that's commonly misunderstood here is the ET intubation. ALS2 does not mean that your medic is the one who did the intubation. ET intubation is regardless of initiation. So the presence of an ET tube that requires an ALS provider may fall under ALS2. Okay, these 3 service levels apply emergency or non-emergency. Now I'm going to get into one that's commonly misunderstood, but it only applies to non-emergency. And that is the SCT, the specialty care transport, commonly used to be referred to as MICU, and still is in many states. Only interfacility transports may qualify as an SCT service level, and it must be, the attending provider must be an EMT paramedic with additional training. Additional training approved by the state. There are many different approved trainings done by the states or approved by the state. So an EMTP with additional training, make sure that that paramedic has documentation of that training. You must also make sure that they clearly document what treatment or care they are giving. So what specialty care they are actually required that is above ALS level transport. So documentation is important here. Remember, SCT, interfacility, EMT must have additional training and documentation of that training. And the requirement for that training must be clearly documented. You know, what care that utilize that training is clearly documented. So those are service levels: BLS, ALS, ALS2, and that's the most common issue that people get confused in, is what is ALS, what is ALS2? Because there is a reimbursement difference. And then SCT, specialty care. Lastly, I'm going to cover a few common billing issues, billing excuses that you may hear. You get paid by a commercial insurer and you're paid less than you believe you should have been. I'm going to let you know, commercial insurers commonly pay you incorrectly. They will not pay you as much as they normally pay the first time. So make sure you know why they're paying what they're paying. Most of your big carriers are getting better at this and paying a suitable amount, but always make sure your biller knows why a commercial insurer is paying what they are paying. Remember that outside of other contract, so if you have a contract with a carrier, this may not apply to you. However, if a call is emergent, you are not subject to any managed care payment schedule. You are not an out-of-network provider. So if the call was emergent, you are not and never will be an out-of-network provider. Another common thing that comes back is they tell you you didn't get paid because you don't have prior authorization. Remember earlier we talked about documenting your due diligence, your attempts at getting prior authorizations. Many of these transports are appealable and payable with that documentation. Especially since last year when a Federal Register rule was issued regarding Medicaid about prior authorizations and making sure transport services are paid if they're doing their diligence. If you go on our website, you can find that notification in our news. Things billers commonly say: you have to call us for claim status. They should be providing you claim status automatically. Either every week or a daily summary. You should be able to access this information on demand, whether that be online or if you do email them, they send you a spreadsheet. So playing phone tag for anything with a biller is a red flag. Because remember, we're talking about your company's cash flow. If you provided proper documentation by your crews, run reports, you've done your pre-eligibility, your PANs, your PCSs, there are absolutely no excuses for untimely filing, not filing their appeals on time, not filing appeals at all, or for lack of follow-up. A call should be followed up until every amount of revenue is collected that you possibly can collect on the call, and then you as a provider can make the decision, okay, we're going to write off the rest or close that call. Remember, there's no mystery to this billing process. There are quite a few rules, and staying knowledgeable on those rules, that's part of why you have a billing agent, a biller. Part of their responsibility is to keep you aware of changes in the system that can impact you as a provider, that are going to affect your cash flow. You need a biller who works with you, not who's just off doing their own thing. One of the last things I wanted to give you this tool that I utilize. It's great. I recommend it even for very experienced billers. It's especially valuable for people who are new to billing. It's called the ABC Quick Guide. Now, this is from a law firm in New York that focuses on EMS, Page, Wolfberg, and Worth. I don't work there. However, I can tell you I highly recommend this resource. They charge $49 for this. It's a little flip book, covers basic rules, things that we've covered here in this video, but it also goes into depth on the coding side, along with some specific area rules for your jurisdiction. It's $49. It's a desktop guide, a little book. Highly recommend that you pick this up. It's pwwmedia.com, or you can do a search for Page, Wolfberg, and Worth. I recommend just to know the billing process, that guide is invaluable. So this is Alex with AngelTrack, signing off of this video. The next one I'm going to bring to you is going to cover some advanced dispatch tools. So be safe out there and have fun.